So Dr. Alex Wiseman is a very well-known figure, and he has been a true collaborator and friend for a few years. He has joined the prior versions of Midwest Transplant Symposium. He remained a medical director at the University of Colorado for many years and moved to another program, Centura, right?
It's a different name right there.
Great.
It changed 2 months ago. That's why we... Yeah.
Wonderful. And he will talk about how to improve long-term survival. Thanks for joining.
In 15 minutes or less. So everyone else gets it. So this is number 13, the talk number 13 for the day, and I really was concerned about heading up against lunch because I knew 100% chance that I was not going to be giving my talk before lunch. It was just impossible to make 13 talks happen before noon. So I will say, Tarek, it's been great to work with you over the last few years, and I always love coming back to St. Louis. I was a med student, I was an undergrad student here, and I have a lot of fond memories of Central West End, and I really appreciate being able to be here. So everyone else gets these little topics where it's just like, what to do with MMF or membranous nephropathy. I have to tell you how to make everything better in 15 minutes. So I've already wasted one of my minutes. So what I'll say is that there's a lot of information that I won't talk about, so it's going to be high level. I will not be talking about how we survive. I'll be talking about graft survival. And I just want to acknowledge Emilio's presentation and his lecture, his publication that describes that we are doing better in terms of graft survival. So if I had an end game, one final word to say, it would be this slide, which is that, I didn't move the slide. Didn't move. Oh, hold on. Maybe I have to do this. There we go. No? Other way? Yes, this slide. So basically, Emilio published this data just about a couple years ago, describing living donor and deceased donor trends in terms of graft half-lives or improvements in graft survival by era. We've improved each era over time, and we now can quote that our T1 half or graft half-life in live donor is 19 years. T1 half has improved from 8 to 11 over 20 years. So if there's one answer to make all of our grafts survive longer, it's to improve living donation. So that's what our focus should be on. That's the punchline. I'm not going to talk anything more about living donation from this point on. So we'll talk now about why grafts fail and just little points about how we can actually improve upon what we do already. So this is an analysis, a single-center analysis of 1,600 recipients over 20 years. This is essentially a Northern European study, but really defined very nicely the primary causes of graft failure as well as secondary contributors. And if you look in the primary column versus the secondary column, TCMR, ABMR is number 1, medical events number 2, but if you look over in the secondary columns, it's TCMR and CNI toxicity. CNI toxicity gets a lot of here, there. Is it truly an effector? Is it truly causing a primary? Is it truly a cause of primary graft failure? Probably not primary, because you can see CNI toxicity of 0.2% in the primary column, but it's a contributor at least in the secondary column of 20% of graft losses. So I think we have to look at both primary and secondary and still address the CNI issue in terms of improving graft survival. So how do we make things better? Well, I think that we first have to stop or prevent alloimmunity, or at least minimize this. I'm not going to be talking about tolerance or tolerogenic trials today, but we'll just talk about what practical things that we can do with current medications, prevent nephrotoxicity, or at least minimize nephrotoxicity, and then slow the progression. So very quick overview of a few of these aspects. So basically, I think that the key here was that ABMR was the leading cause of graft failure in terms of primary causes. Our primary causes of graft loss start with the formation of DSA, moving through the progression of peritubular capillaritis, C4D staining, glomerulitis leading to fibrosis, transplant glomerulopathy, and then graft dysfunction and failure. So basically what we have to do is try to intervene at the de novo DSA phase, and then I'll show you a little bit of information about do we have therapies once we get into the disease manifestation phases. So I'll skip this slide in the interest of time. Just know that tacrolimus does have a role in terms of prevention of DSA. As Dr. Brennan commented, MMF doesn't prevent DSA, but CNIs do, tacrolimus in particular. We found within our clinical experience, looking at therapeutic ranges, what is the right dose, what is the right exposure, we have to deal with adherence issues as well as our drug dosing issues to try to make this better. So borrowing from information from INR studies in stroke, prevention of stroke, we looked at time and therapeutic range as a prevention of DSA, prevention of rejection, prevention of graft loss, and basically looked at the first year post-transplant in 500 or so transplant recipients, all on tacrolimus-based therapy, all on the vast majority on MMF-based therapy. If you had a time and therapeutic range of 5 to 10 with your tacrolimus exposure, and if you were in that range for more than 60%, so it doesn't even have to be like 90% success, just even 60% time and therapeutic range, that associated with freedom from de novo DSA, freedom from acute rejection, and improvement in 5-year graft survival. So another take-home point, improve living donation, dose your tacrolimus appropriately, and really focus upon adherence. So what about the later phases? So now let's pretend we unfortunately have de novo DSA, or we have DSA and we have ABMR, and we have this chronic, unrelenting graft injury that we have no solution for. I'll just give you a couple little tidbits of, well, what can we do next? So one is the possibility of using an inhibitor to IL-6, because IL-6 seemingly is quite important in terms of T-cell maturation, as well as the promotion of antibodies and antibody formation from plasma cells. So two very important pathways that IL-6 plays a role upon. We actually now do have a couple, these are just little, again, tidbits of information of things to be aware of in the future. Tocilizumab actually has been used in one single center experience from Cedars-Sinai, looking at patients who had failed other antibody removal / treatment therapies, taking 75 patients, chronic active ABMR, plus or minus transplant glomerulopathy. The control arm was essentially those that received IVIG Ritux plasma exchange. Those that failed also then received tocilizumab, 8 mg per kg monthly for 6 to 18 months, followed for up to 7 years. You can see the differences in graft survival, those in the tocilizumab arm versus standard of care. And you also see that the decrement in GFR over 7 years is, that slope analysis is actually fairly impressive, with just a decrease of 4 mils per minute per year. So that is an enticing possibility. That you can also look at maybe inhibiting not just IL-6, but IL-6 receptor. There's a clazakizumab study that's ongoing currently. This is just the preliminary study that formed the basis of ongoing studies. This, again, is a study that was a phase 2 trial, 20 patients, randomized 10 and 10 in patients who had DSA-positive ABMR and were greater than a year after transplant. Placebo. Then at 9 months, we're given clazakizumab versus clazakizumab subcutaneous monthly. You can see the decrement in GFR was slowed in the claza arm versus the placebo arm. And then the placebo arm, patients were placed on claza and essentially had slowing of that slope of GFR fall. There were some infections to wrestle with, so it would be very interesting to see how these trials progress in the coming year. It's been very difficult to enroll for those clinical trials because of the timing of finding those patients who have this chronic active ABMR post 1 year, but still with reasonable graft function, who you feel comfortable in randomizing. How else can we make things better? Well, we should probably maybe think about matching our kidneys better. And so instead of just looking at general HLA matching, we could look at epitope or eplet matching, and then titrating our immunosuppression, or actually using that information to promote longer-term graft survival. So basically an epitope is a subunit of the HLA protein, and the conformational change becomes the eplet. And so you can have a number of eplets that are essentially mismatched with your donor-recipient pair, that is different and distinct from the HLA molecule itself. And so when you actually try to match for eplets rather than alleles, there's been a fairly large study, this is just a gross summary of the fact that in this setting of 926 pairs, looking at eplet mismatching load and its relationship to antibody-verified DSA, rejection, graft loss, graft dysfunction, graft failure, it turned out that if we start to look at matching for HLA DQ alpha 1 beta 1 eplets, mismatches, were associated with all of these functions. So taking this information, there's also been some other studies that have essentially paired this with adherence studies. So you take this information from a patient-level data, and you could say, well, this individual might be plus minus on their tacrolimus exposure. You measure it through an electronic pill monitoring systems, and then you correlate that with the eplet mismatching or epitope mismatching that they have, looking specifically at the DQ epitope mismatching greater than 17 as a high load, for example. You can see that those individuals that were considered to be non-adherent through monitoring and had a high epitope mismatch load had decrease in rejection-free survival and graft survival. So if we talk about improving outcomes, we can't control for all humanity in terms of adherence and non-adherence, but if we match better, we may be able to prevent graft rejection to a greater degree and improve graft survival. So next couple things, prevent nephrotoxicity. So we just talked about the fact that CNIs were very important for DSA prevention. Well, now I'm going to tell you that is one of those most important things in terms of graft dysfunction as a secondary cause. We now know about the belatacept data comparing cyclosporin to belatacept and seeing improved 7-year improved 7-year GFR over time. The caveat to this was the fact that there was an acute rejection rate that was higher in the belatacept arms versus the cyclosporin arm. There's not been an uptake in utilization of belatacept because of perhaps some of this reluctance to overcome the CNI, the rejection early on that was seen with belatacept. And in fact, this was also, there's issues with comparing it to cyclosporin and also using IL-2 receptor antagonists. Are we truly comparing apples to oranges versus apples to apples in terms of what we're truly practicing in our given days? This study did have the hint of not only preventing graft loss, you can see that the Bella arms versus the cyclosporin arms, but also preventing DSA formation. So these are kind of common features. You may see more cellular T-cell mediator rejection with belatacept or co-stimulation blockade in a CNI-free arm versus cyclosporin. But again, some caveats about the cyclosporin being the control arm were a bugaboo until we had a more recent study that was what I consider to be a little bit more real-world experience in terms of immunosuppression in modern day. This is a steroid-free regimen using depleting antibody therapies, again, comparing either alemtuzumab Bella, Rabbit ATG Bella versus standard of care, quote-unquote, ATG Tacro, all with steroid-free, all given MMF. And basically the punchline at the 2-year point was still that we had biopsy-proven acute rejection at higher rates in the CNI-free arms compared to the tacrolimus arm. However, the little hint of future events were that the estimated GFR less than 45 was in 8% of this arm versus 19%. This was formed mostly by patients who had acute rejection with severe decrements in their GFR. The mean GFR, all disclosures notwithstanding, the mean was actually the same within these groups, but this is just a hint of things potentially to come, but definitely not necessarily embraced as standard of care because of these features. So why is it not standard of care? We have higher acute rejection rates, more severe rejection when we do see it. There was a little signal for PTLD with co-stimulation blockade. The IV administration and cost was a potential issue. Some patients may be reluctant to have monthly IV therapies. These may be overcomable if the data were truly so impactful that we could change our practice patterns and provider approach to this. So there are new stimulation blockade agents that are under development to avoid CNIs in the future. We hope that some of these do make it through the phase 2 into phase 3 trials. We've had a couple that have not quite made it past the acute rejection phases and GFR phases on the anti-CD4 realm. Lastly, I just want to say in the interest of time, one slide or one piece of information about slowing the progression of CKD. I know that this has been mentioned a number of times in a number of different ways in other presentations. We do have the DAPA-CKD trial that has led to general practice of CKD that should be revolutionized. The question is whether or not we are practicing what we preach and whether or not this is truly applicable to the transplant patient population. We have very little data in transplant, but this is actually the most recent data that just was within the last year or so. A multi-center tertiary hospital study that basically looked at 2,000 kidney transplant recipients, of whom there were 226 SGLT2 inhibitors, and it basically behaved very similarly to the DAPA study. You basically see a composite outcome of reduction in GFR, death, and renal function that's cut by half. Mortality is cut by 70%, graft failure cut by 70%, doubling of serum creatinine cut by half. So basically, what this says is that we don't have, the problem is in transplant, we do not have a randomized controlled trial. And while we're trying to promote and create a randomized controlled trial using SGLT2 inhibitors, we probably are going to struggle to get that. And we have to essentially practice what we preach. So we all are talking about doing this. We're all making sure that this is the next phase of transplant care. I think that we do have some fears about rejection or infection issues that have put us on the sideline. I think that we have issues with following creatinine and GFR so closely that the decrement of GFR that's going to be seen right after we put patients on this is going to scare us a little bit. But I think we just have to kind of motivate ourselves to do this in clinical practice. So with that, we'll just kind of say, what can you take home from this is keep your tacrolimus levels at greater than 5. We hope to have better treatments for chronic antibody-mediated injury. We really want to avoid DSA. We hope that sooner or later we'll have a CNI-free regimen that can be embraced by the community, but we really have to overcome this early acute rejection issue. And then finally, again, we just need to keep exploring this probably more clinically than waiting for a randomized trial. Thank you. Yeah.
Alex, one thing that we're struggling with in our program in the context of paired donation is how much eplid matching should factor into organ acceptance, and should we be turning down a high eplid mismatch with cross-magnetic versus
Right.
the life of waiting for a
Right. So that gets into the point where with paired exchange and with living donation, there are opportunities using molecular assessments of HLA to take a compatible pair and make them even more compatible. And I think that is an attractive prospect. I think that you have to marry yourself to programs that will provide you molecular mismatching and understanding that technology. I think that it is going to add marginally at this point, but it will add to graft survival.
And the same,
Yeah.
sort of, we've gone to regarding it less and picking the
Yeah. So then it becomes an expeditious thing. So do you take the easy route, which is the transplant right in front of you, or do you try to work through paired exchange and the time that it takes and the patience that we all have to have in terms of finding that better match? And so it is an issue in terms of making it more institutional, but I think that it probably will incrementally benefit our transplant outcomes.
Dr. Weissman, I was just saying, nice talk. I was going to say about the SGLT2 inhibitors, I like your approach towards that.
Thank you.
I brought up to my doctor's team here, I said, why not? I've been on for a year, no issues. I think most people are trying to figure out what you can do to hold on to your kidney. So just as a thought, I completely agree with you.
Yeah.
The other thing I would just say too is just, I think for the community, this is a general comment. These outcomes are improving, but one thing that's missing in discussion is patient participation in life, patient outcomes. You know, if you look at the data that came out a couple years ago, Social Security, unemployment is a huge issue. And the only reason I bring this up, not as a criticism, but the FDA hears this message, but the FDA thinks everything's great, there's not a need for new treatments. Just something to consider.
Yeah. So many ways to take this talk, and that way I would have loved to gone down that road, to go down that road as well. It was- yeah, I appreciate that comment. Yeah.
Thank you so much.